Good morning, everyone, and welcome back to day 2 of the 80th Presidential Advisory Council on HIV/AIDS, also known as PACHA. My name is Marlene McNeese. My pronouns are she and her, and I am one of the co-chairs, and I currently serve as Deputy Assistant Director with the Houston Health Department, overseeing our Bureau of HIV/STI and Viral Hepatitis Prevention. For everyone in the room here today and those watching online through the live stream at HIV.gov, just welcome. I am full still today from the amazing days that we have spent together here in my home city. And I just have to say, I am proud to be a Texan today because of the amazing leadership and work from my fellow colleagues and advocates who are serving their community in mighty and innovative ways despite our challenging environment. So I really just have to say thank you again, and please help me give my fellow Texans a round of applause. And we have yet another full day today, so I won't be long before you this morning. I will turn it over to my co-chair, Dr. Vincent Guillermo Ramos, for his opening comments.
Good morning, everyone. It's wonderful to be back for the second day of our formal meeting, the third day here in Houston, Texas. I think, Marlene, you have used the word full a number of times, and I'm just going to sort of borrow from that language. I think it's been quite an impactful meeting. There are a number of issues that I just want to share last night as I was reflecting that are really sort of weighing heavily in my mind, and I think that's work that we as a committee should consider very seriously pursuing. The first is that I heard lots about Medicaid expansion and individuals in Texas and elsewhere that are not covered and have no way of being able to access primary care and HIV care. There was quite a bit of discussion about formularies and ADAPT and whether or not single tablet versus sort of multi-tablet, certain kinds of injectable medications, et cetera. How are those decisions being made at the state level? And is there a role for the federal government in terms of incentivizing states to adopt the best evidence as far as how those decisions are made? I also heard about Medicare and preparing Medicare in terms of what's happening with people in our country living with HIV and the importance of Medicare being in a better position to provide support. And finally, I was struck by a lot of the conversation regarding criminalization and how we still live in a country where there are sort of biased and unscientific laws that criminalize people living with HIV. Those are things that I heard yesterday that I think are in my mind, ripe for us to address as an advisory committee. And so I hope that we will do that. Special thanks to all the PACHA members. I feel like the passion and the specific recommendations, the clarity and the commitment was palpable. So with that, I am happy to turn it over to Carolyn, who's going to be helping us with the roll call today. Thank you.
Thank you. Good morning, everyone. Kay Hayes, Dr. Tim Harrison, Kristen Rohan, and a few others are with Admiral Levine for the National Syphilis and Congenital Syphilis Endemic Task Force meeting. So they should be here shortly. But to kick it off at the roll call, I'll say your name, and if you can also say your organization, location. So starting with PACHA, PACHA co-chair Marlene McNeese.
Present, Houston, Texas, Houston Health Department.
PACHA co-chair Vincent Guillermo Ramos.
Present, Washington, D.C., Institute for Policy Solutions, Johns Hopkins University.
Guillermo Chacon.
Guillermo Chacon, New York, Houston, Florida, North Carolina, PACHA member.
Philip Chan. Philip Chan. Tori Cooper.
Present, Human Rights Campaign Director of Community Engagement, Washington, D.C. and all across the country.
Rania Copeland.
Rania Copeland, CEO of Equity and Impact Solutions, Los Angeles, and worldwide.
Mackenzie Copley.
Mackenzie Copley, co-founder and CEO of 110 Health in Washington, D.C.
Alicia Diggs.
Good morning, Alicia Diggs, UNC Chapel Hill, Community Engagement Manager of the CFAR.
Jennifer Cates. Jen Cates. Paul Kawada.
Paul Kawada, NMAC, Washington, D.C.
Duvia Lozano.
Duvia Lozano, Phoenix, Arizona, Chicanos por la Causa, Latinos Unidos contra el SIDA.
Tiomi Luckett.
Tiami Luckett, Little Rock, Arkansas, Transgender Law Center.
Jesse Mylan.
Present. Jesse Mylan, AIDS United, headquartered in Washington with staff in 17 states.
DeAndre Moore.
DeAndre Moore, present, native of Beaumont, Texas, and board member to AIDS Vaccine Advocacy Coalition and Prevention Access Campaign.
Leo Moore.
Present, Leo Moore, LA County Department of Public Health, Los Angeles, California.
Laura Platero.
Present, online, Northwest Portland Area Indian Health Board, Portland, Oregon.
Kayla Quimbley. Kayla Quimbley. Natalie Sanchez.
Natalie Sanchez, Los Angeles, California, Director, UCLA Los Angeles Family AIDS Network.
Patrick Sullivan.
Present. I am at the Rollins School of Public Health, Emory University in Atlanta, Georgia.
Jeff Taylor.
Present, HIV and Aging Research Project, Palm Springs, California.
Marvell Terry II.
Present, cultural organizer and activist, Atlanta, Georgia.
Hansel Toots.
Present, Associate Professor of Medicine, University of Miami, Miller School of Medicine.
Carol Trustin.
Present, Association of Nurses in AIDS Care. We're a global membership organization, and I'm in Philadelphia.
Defina Ward. Defina Ward. Daryl Wheeler.
Present, New Paltz, New York, State University of New York, New Paltz.
CDC HRSA Advisory Committee on HIV, Viral Hepatitis, and STD Prevention and Treatment, or CHAC Liaison, Wendy Armstrong. Wendy Armstrong. Thank you. And now for our federal partners. Tim Harrison. Tim Harrison. John Ogutumilade.
Present, EHE Coordination Lead, Office of the Assistant Secretary for Health.
Jonathan Jono Merman. Jono Merman. Robin Neblett Fanfare.
Morning, Present, Division of HIV Prevention, CDC.
Erna Hughes.
Good morning, Present, Health Resources and Services Administration, Bureau of Primary Health Care, Rockville, Maryland.
Laura Cheever. Laura Cheever. Andrea Jackson.
Present at the Health Resources and Services Administration, HIV/AIDS Bureau, Rockville, Maryland.
Mehran Massoudi. Mehran Massoudi. Kristen Roja. Kristen Roja. Mary Glenshaw.
Good morning, everyone. Mary Glenshaw, NIH, Bethesda, Maryland.
Jessica Lee. Jessica Lee. Michelle Schreiber. Michelle Schreiber. Rita Hartgrove. Rita Hartgrove. Casey Nope. Casey Nope.
Present, Casey Knopp, Administration for Community Living.
William Dilday. William Dilday. Rodrigo Chavez. Sharonda Brown. And Caroline Talev here. Oh, sorry. Senior Management Analyst in OIDP and alternate designated federal officer for PACHA. Thank you.
Thank you so much, Carolyn. So we've got a really packed second day of our formal PACHA meeting. This morning, up until lunch, we'll have an opportunity to hear from local folks around issues that are specific to rural and urban areas. and some of the challenges. We also will have PACHA-to-the-People after lunch, which I think will be an important time to hear directly from community. I understand that there's some groups that are here and that are also on their way that will provide some important perspective. And we're hoping to have time this afternoon for discussion, and we will adjourn around 3:45. So without any further delay, I am super excited to be co-facilitating with Marvell Terry II. So Marvell, I am not going to spend a lot of time introducing you. I know you've prepared some wonderful comments, and so I'm going to turn it over to you. Thank you.
Thank you, Vincent. To my PACHA colleagues, federal officials, and to the community, good morning. Good morning. I feel like Marshall Fudge, good morning. Lucille Clifton in her poem, Won't You Celebrate Me, says, quote, come celebrate with me that every day something has tried to kill me has failed. I think it is appropriate before we move forward that we pause and celebrate the resilience of Texas, of the South, of community. And so can you just pause and in whatever way that you celebrate, to celebrate the activists and the resilience of people living in Texas. By 1995, the cultural and artistic hub that is the South was tired of being put down. During that year's Source Awards, Andre Benjamin, also known as Andre 3000, of Outkast gave Southern hip hop its battle cry. Quote, the South got something to say, end quote. I believe that our conversation today about rural and urban perspectives will illuminate what poet and lyricist Andre 3000 was saying, that not only does the South have something to say, but also Texas has something to say. My name is Marvell Terry II, and I'm a member of the Stigma and Disparities Subcommittee and chair of the HIV Criminalization and Discrimination Work Group. I'm a person living with HIV and a proud Southerner. Yesterday, we learned that in the face of racism, challenges in infrastructure, antiquated laws, stigmatizing checkpoints, and just outright stupidity, the Texas HIV community, rural and urban, has been creative and innovative in its approach to addressing HIV and the many social and structural determinants of health that often push people to the margins. Communities that we heard from for the last couple of days, the Latinx community, cisgender Black women and Latinx women and brown folks. The first half of this panel is about rural communities. You will hear from individuals who have made their work possible despite the many barriers that systems and policies have created in the South and in Texas. I will ask the panelists to introduce themselves and please describe the work that your agency does in rural areas. We can start here.
Good morning. Good morning, everyone. My name is Samuel Hebe Goins. I use he, him pronouns. I am the HIV, STD, and viral hepatitis prevention director at the Texas Department of State Health Services. I have been working in this field for almost 14 years, and I am just deeply passionate about the work that we all do, the work in public health, trying to improve healthcare services, reduce health disparities, and improve the lives of those that are affected by HIV. Prior to my tenure at the health department, I was one of the co-founders of the Austin PrEP Access Project, today known as the Kind Clinic. This is the first volunteer-led standalone PrEP clinic in the United States. Prior to that, I started off in public health, actually as an intern at the Virginia Department of Health, working at the AIDS Drug Assistance Program during a time where there was an ADAP shortfall. And as a young person who was still not out completely, I was really taken back by just the challenges that our public health systems have in terms of funding, in terms of client services, and supporting those living with HIV to And so that really kind of motivated me to pursue continuing down this trajectory that I was on. I joined the CDC as a fellow and made my way to Texas. I was assigned to the San Antonio Health Department, where I worked as a disease intervention specialist. And I, throughout my career, I have really just been really inspired by the people that I've worked alongside with and their deep compassion and commitment to this field. And so I'm very excited and honored to be here, and I look forward to this conversation.
Buenos dias. I am Ana Yencia Almaraz. I am the Prevention Program Manager for CAN Community Health in Arlington, Texas. Our clinic in Arlington, Texas, though it's based there, does operate in several counties, including Wise, Somerville, Erath, Hood, Johnson, and of course, Tarrant County. We do this because we understand that those areas are largely underserved, especially when it comes to accessing HIV treatment and prevention services. Our clinic does have the ability right now to offer a varying amount of services. We do provide HIV treatment and prevention, and we also provide NPEP services. We have an on-site dental clinic that's open to the community. We also have an on-site pharmacy that's open to the community. We have case management for people living with HIV. We have patient access specialists that help anyone regardless of their status. And then we also have peers and, of course, our early intervention services team. So as a whole team, we really do try to approach care in a status neutral way, making sure that we use what resources we do have available regardless of the individual status. And of course, we have Ryan White funding that helps in many aspects, but we also use our relationships in creative ways to try and fill the gaps. One of those being in our rural areas. And so what we do in our rural areas to really meet the need there is partner with organizations and or companies that may be considered non-traditional. We focus on work with social service organizations, food banks, re-entry programs, substance use centers, truly anyone and everyone that will allow us the space. In addition, we also do have a program that is called CAN Connect. CAN Connect allows us to place a laptop in these other clinics or in these other facilities, sometimes in health departments, so that we do have the ability to offer telehealth services to those patients. We also work with labs nearby in order to make sure that they all have access to labs close to home and they don't have to commute into the cities that are closest to them, because sometimes we are talking about over an hour commute. In addition, our mobile unit and our prevention team, my wonderful prevention team, goes out into these areas every month and they make sure that they are there available for the community. Our mobile unit is also equipped with telehealth services. And so if we do need to engage someone in care rapidly, we are able to do so via our mobile unit and our prevention team, who is trained in phlebotomy as well as initiating some of that paperwork, whether it's necessary for Ryan White or other assistance programs. So we really truly try to meet the need and engage them right then and there, and making sure that we do, of course, put the patient first, which also brings me to our partner agencies in rural areas. Sometimes we are able to work with a partner and get them connected to care in those areas instead of having them be a patient of ours. And again, we really assess what is going to be the best case for the patient and make a decision from there. And our providers are also really big about doing provider to provider education. So our providers are able and willing to speak with other providers and give them the basic information needed to be able to treat HIV and or offer PrEP services.
Good morning, everyone. My name is Dina Hughes, and I am the Chief Executive Officer for Triangle Area Network, otherwise known on the streets as TAN Healthcare, and we are located in Beaumont, Texas. And I am here today wearing multiple hats. And my dad used to always say, just wear one hat. And what he meant was just be authentic in what you're doing and where you are. And so I decided with all the different hats, I'd just sew a hat together with all the different pieces. I am a woman living with HIV. I have been living with HIV since the age of 21. I am now officially 25. I am 54 years old, and I do remember a time when I was told by my diagnosing physician that I had 5 to maybe 10 years to live. So every day is a joy. Every day has meaning. Every day has purpose. I am also a mother. I have a beautiful 28-year-old daughter. She is actually here. I made her take off from work to show up. And she has been rolling with me diligently her entire life to the point where she is now a youth case manager for an HIV transitional living facility. And so I am also contributing to the workforce. So thank you, Candace, for coming and being a part of this today. I'm also an advocate. When I was diagnosed at 21, I made it my personal mission as a college student majoring in communication that there was no way I could live a life of silence around this. And I don't have any judgment on how anyone else chooses to engage, but for me it was give it away, right? And if people can deal with it, they can. If they can't, they can't. And so that led to the last 30 years working in the community as an advocate, as a young woman working in the jails and working in the community. And as I got older, being able to actually work within the institutions, being at the decision-making table, making choices about dollars. And I recognized and have always known the importance of having the positive voice at the table, no matter what decisions need to be made. So I am very honored to be here with you all today. TAN Healthcare, and I have a group of people walk in a minute. It's my team. I had them also come from Beaumont to come in. Oh, y'all are right on time. So this is, you have to share the light. So this is a representation of the team that works in Beaumont with me. The first person I just want to highlight, though she's wearing her Delta gear, is my Director of Medical Services. Her name is Dr. Maisha Clifton. And the crew, right? But I wanted to just particularly point her out because I think it's important to recognize the providers who are in these communities and who are doing this work. TK, raise your hand. That's outreach. He goes out. He does the work in the street. And so I'm glad that they were able to take away some of their time to come and be a part of this because I want them to see that though we are rural, we are not basic. On any level. We are not basic. TAN Healthcare is an FQHC. We're a federally qualified health center, but we have the unique distinction of having been a AIDS service organization for 37 years. We were the first ASO in Southeast Texas, and we remained that way for many years until we were joined by Legacy Community Health and the amazing work of Smart Health Clinic with my fabulous colleague, Cordella. We do all the work. We have the services. We have the telehealth. We have the rural health. We have multiple locations. But I didn't know rural. I'm a transplant. I'm a Houstonian by raising. And so when I made the transition to the rural community, it really felt like I went from going 100 miles an hour with Miss Marlene McNeese to almost a sudden stop. Because the information, the infrastructure, that it wasn't there in the rural community. And if it hadn't have been for Cordella asking me out for Thai one night, we had to do it on our own. And so one of the issues that I hope to address with you all is the issue of infrastructure in rural settings. But I am very honored to be here, very happy to be a part of this ongoing conversation. And I look forward to hearing from my fellow colleagues as well. Thank you.
Good morning. I am Cordella Leon. I'm the HIV program coordinator at Baptist Hospitals of Southeast Texas. And by trade, I am a registered nurse. I am a member of ANAC. I am also the community co-chair for the Texas HIV Syndicate and the president of the Boston Congress of Public Health. That's all for now. That's all for now. I know we all want to get out of here early. And don't be bothered by my accent. I know I am Jamaican with a touch of Texan. So so you'll be all right. You're in good company. Baptist Hospitals of Southeast Texas is the only regional hospital that provides routine HIV testing and linkage to care in their emergency department. I am grateful for the transformative leadership of our hospital that embraced this program 13 years ago when Jefferson County was ranked 4th in case rates with people who are living with HIV. I'm also grateful to the Texas Department of State Health Services that walked into Beaumont and believed that a rural hospital could make a difference in HIV testing and linkage to care, so that by 2018, Jefferson County was ranked 12th in the state with people living with HIV. Baptist has been the leader in healthcare in the community. Our service area is 8 counties. It's just about the size of Delaware. We are rural. Regardless of what our population size is, we are rural. We do not have the infrastructure that urban communities have. There is no transportation that links people between cities. And for that reason, we have to be innovative. We've managed to turn that challenge into change in that we identify our partners who have common interests. We have succeeded in building private-public partnerships that are addressing HIV and Hep C. Here we have syphilis in that kind of a syndemic approach to healthcare. In doing so, I must say that it has allowed our community to also look at stigma in a different way when it comes to HIV testing and linkage to care, because routine testing prevents the stigma of testing. And since we leveraged our routine testing to incorporate Ryan White care, then routine care destigmatizes HIV care as well. I know there's going to be more that we will discuss about hospitals and how we function in rural communities. So I'll leave that for now until we get into the nitty-gritty of our questions. Thank you.
Thank you. Thank you so much. We're going to have an exciting conversation around rural, and in our framing of this conversation, we attempted to define rural, and we recognize that every agency, every federal agent, every department of government define rural as something different. And so we wanted to allow our panelists to kind of contextualize that for us. Could you help us to better contextualize what are the core issues for individuals vulnerable or living with HIV in rural areas?
One of the issues that I know communities face is a lack of expertise for HIV care. And when we look at that challenge, we also understand that maybe the solution, as I bring that challenge to you, is providing our graduates or medical graduates with relief for student loans to practice in rural communities. I mean, it is unrealistic to believe that a new graduate is going to pick up their bags and move to rural communities to practice when they do not have an airport, an international airport. There is no space for entertainment. There's probably questioning the education system for their children. So we have to make it so much more enticing that they will come to rural communities.
To add to that, we also see stigma, and of course that exists everywhere, right? Unfortunately, but in some of our rural communities, they are so small that if one person finds out, the whole town finds out. And even with something as simple as getting tested for HIV. And so our organization does take the opportunity to advertise health screenings instead of rapid HIV tests. And in efforts to normalize it, we also can pair it with a blood pressure and a glucose check with equipment that we purchase, from a Walgreens, a local pharmacy, but in efforts to normalize not only getting tested for HIV, but also not be known as, why are you getting on that bus that does HIV testing? Because again, we're talking about really small communities. A lot of them still have really strong ties to religion, faith, etc. And so keeping all of that in mind, how do we come into a community that is so small in a neutral way?
I just wanted to add to that conversation. I think those are the two biggest issues, infrastructure and stigma. So I grew up in a small town. So I'm living in Austin now, and that comes with a lot of privilege, living in a big city inside of a bubble. But I grew up in a small town in Southwest Virginia with a population of 4,000 people. And so if I was a young person trying to seek out testing services, I didn't know where to go. My dad was the town doctor, so everyone knew him, my family, and so that sort of thing, where that connection, where everyone knows each other, everyone is in your business, that can be difficult, and that can help perpetuate the stigma and fear to going out and seeking services. I think in terms of infrastructure in rural health, so I'm a numbers person, so. Texas is a big state. We have 254 counties. 171 of those counties have a population of under 50,000 people. And so when you look at that, we have, while we concentrate our efforts where the epidemic is where the greatest needs are, it also, it creates a lack of visibility for all of the rural communities. And I think when we talk about service gaps, what we're talking about is these counties where someone has to, they're one medical doctor, or they're one maybe HIV testing organization, or maybe not even that. Like, we're talking about just a healthcare provider. If they have a friend or relative or someone that they know that works there, they may not be that, they may not want to go there and seek services. And so I think that is definitely some of our biggest challenges, is looking at infrastructure and the stigma and options for services for people.
I think one of the things I separated when I looked at that question was, the core issues for the possibles, right? I think I heard that word used yesterday as opposed to negative, but the possibles, as well as the, people living with HIV. Because we were an AIDS service organization, the community already was aware that if it itches, scratches, burns, or whatever, come to TAN. That was a well-known fact. As we transitioned into the FQHC space, we now have the ability to serve, but yet everyone still knows if this is what you need, come here. So for the positive community, when you come in and you're getting screened, you have providers who know how to navigate. I didn't say it, but my amazing provider is a dual certified HIV specialist in the rural communities. So not just a provider, she specializes. And so care is one part of that dance. And I believe we dance that very well when it's getting them into get screened and get into care. But for the possibles, that's a whole nother at-risk conversation. We started talking recently about where are the 18 to 30-year-old African-American women in Beaumont? Guess where they are? Houston. On the weekends, Friday, Saturday, Sunday. Well, now they go to the park on Calder a little bit, but they're here and they're in New Orleans or they're in Lake Charles. They're leaving the community and they're going out and they're having a wonderful time in a much bigger city with a greater level of exposure, and then they come home to us, and once there is a need for that screening or that care, now we're saddled with the burden, right, of being able to provide that care. And so I think what we need, that core issue for people who are not living with HIV, is we want to prevent. So prevention is a big part of this conversation. And I'll be honest, one of the most difficult things for me to wrap my head around, especially after having lived with all of you for so long, and we talk about Black and brown and women, go to Kirbyville, Buna, Jasper, Newton, right? 2%, 4%, 6% Black and brown. But yet the poverty rate, high. Unemployment, high. Drug use, high. So I think we've got to figure out how to be a bit more incorporating, because it is strange to go somewhere and go, what about white poor people? That sounds crazy, right? Saying that, but it's still a reality. And so getting those prevention messages into rural communities where you have issues around faith and you have issues around politics and you have all these barriers, they're different than what you would experience, I think, in the urban settings.
Thank you for that. I want to continue to interrogate this idea of rural perspectives and what does that look like. And so this question I didn't send to you all in advance, but we're gonna flow. Is that okay? Okay. Paint for us, what does infrastructure look like? What are the infrastructure challenges that you all are experiencing in rural areas? Sure.
Cordell and I have been living infrastructure for several years now. That is by far one of our biggest challenges. And when I say infrastructure, I'm talking not just about organizations partnering together to use the resources we have wisely. We're talking about decision making. I am now of the mindset that Houston should not be making a single decision about what happens in Southeast Texas. Not a single decision. And we have to use our data, we have to send that information in, but we don't necessarily hear the full conversation, nor are we able to really get that access that we need to a structure that will allow us to use the resources, whether it's the health department, the Jefferson County Health Department. We have to be able to connect all of these pieces together. Cordell and I can't keep driving to Houston to talk about what's going on in rural America. I can't take my staff out of what they're doing and bring them somewhere else. We need to be able to have those resources and those conversations about our dollars and the services that we need. They need to be done more locally. One of our challenges also is that when you're looking at counties have a different political structure than a city has. They're like many fiefdoms, right? And so you have to make connections with each of these county entities. You have to figure out how to benefit them, how they'll benefit you. So if I'm doing it, Cordell is doing it, someone else is doing it, we have no coordination. And so somebody either walks away with all the pie and none of the pie. So part of that is how do we, and whether it's capacity building or technical assistance, how do we do that? I will say that the state has definitely stepped up in the last year or so in pulling us together, but I'm not necessarily funded to do this work. I come to the table as a volunteer. So you're expecting people to come to the table and do this work, but there are no dollars to support the work you're asking them to do. So.
Anyone else would like to comment on infrastructure?
And I agree with Dina. That would have been a part of my response, very nicely said. And I'll go into the structural issues that rural communities have, especially in the South. Understanding our risk for disasters and the impact that it plays on our community, on personal lives. When someone has gone through Harvey, lost their home, tried to rebuild, and Imelda knocks it over, and then try again, and another storm comes in. It's not just that mental displacement and not having the access and resources for mental health care. The cost of housing has now gone up because housing is scarce. Housing is a primary need for health care. And in rural communities, when we have to push people further away from the resources, from their doctors, from their grocery stores, from the hub of their activities, then we're pushing them pretty much into non-existence. And so that is a big issue. And I do understand that as we sit at the table, we're trying to find solutions, but more has to be done intentionally on how we look at housing as a preventative measure in healthcare, because none of our patients are one-dimensional in just living with HIV.
Thank you for that. To position this question for you, you mentioned hospital systems earlier. How do we best utilize hospital systems in rural areas?
I'm going to say this with a backdrop that, as we all know, sitting at this table, many rural hospitals are closing. If they're not shutting the door completely, they're closing essential services. Just last night, I heard that one of our rural hospitals will be closing their mother-infant unit in Nacogdoches, okay? But how do we utilize the system, you asked? Hospitals are the central ground for anybody, regardless of age, race, ability to pay, gender, or sexual identity. What we have found at Baptist is by doing routine screening in our emergency department, we've been able to identify people who never thought that they would even have been exposed to HIV. We use the CDC guidelines, screening those who are 18 and older. Our oldest patient was 72 years old who presented with gout, had no idea she was living with HIV. So hospitals also have the neutrality that can engage other entities in the community. Because I know for a long time in the HIV sphere, funding caused people to be territorial. This is my patient, that's your patient, this is where I screen, that's where you screen, so on and so forth. But when hospitals get in, because that's a neutral ground, they can pull other people to the table to have the productive conversations that are needed to care for the community. There's also that respect that the hospitals have. And we, Dina and I, TAN, Legacy, all the players, we have worked together around that. We call them our stakeholders, okay? And this works also with bringing in pharmacy. For many of us, I'm not a pharmacist, but my patient needs the assistance of a pharmacist. The hospital is able to leverage that. We bring in the health departments as well. And when I talked about using a syndemic approach to addressing HIVs, where else does it happen than the hospital? That's where people with mental health issues are. That's where your diabetic who's now finding out that they are living with HIV or Hep C, that's where they are. So we do have the opportunity to lead on this. I do understand that it is strenuous because who will pay? That's always the big question. But when I look back and remember our response to COVID, Operation Warp Speed required private-public partnerships. The federal government needed pharmaceutical companies who already had vaccines ready or could make those vaccines. Hospitals can leverage private-public partnerships to address HIV or any syndemic that's out there. And the discussion yesterday was about funding and the requirement for, that applicant to have a certain amount of money. Well, hospitals have that background. They can get into the game, they can make the difference, and they can bring in other partners as sub-grantees to address the issues.
Can I ask you a follow-up question? In rural areas, what is the relationship between hospitals and community-based organizations who are fighting HIV?
I can speak specifically to Beaumont, and I'd say we have a wonderful, respectful relationship. We respect the autonomy of our CBOs and ASOs and what they can and cannot do, and they respect us as well. We stay focused on the client, the patient, the consumer, or the issue. I know that, and I'll share this with you. We work closely with our health departments. We need them and they need us. And it was probably 9 years into our program that the director of the health department came to me and she said, Cordella, I need your help. We are giving our first responders 30 days off with pay when they have an exposure to a bloodborne pathogen. We have to revamp our policy. And I brought in the experts, the medical scientists, the community liaison, teaching them about HIV exposure. I brought in the pharmacist as well. And now the city is saving money on their salaries because they're not giving people 30 days off with pay while they pay overtime to fill those slots, because they didn't understand that when somebody was exposed to HIV, they're taking the same medication as people who are living with HIV take every day and go to work. But because the hospital had the trust of the community, we were able to help them to do better and to be on the cost savings end of an HIV exposure. Hospitals can also provide PEP in the emergency department. It doesn't take funding to prescribe PEP. It takes the will to prescribe PEP. We prescribe PEP and PEP in our emergency department. And Lila and Brandy are here, our fearless social workers at Smart Health. Patients are linked to care after they receive their first dose of PEP in the ER. They're given their prescription and they follow up with Smart Health. Hospitals can also help with re-engaging people in care. In our inpatient settings, when a patient is admitted and you're going through that assessment, do you have diabetes, hypertension, so on, HIV and Hep C are there. And it's not just do you have or HIV or Hep C, is are you in care? If they're not in care, I get a fax right away. So while that patient is in that bed, I'm at the bedside. Hello, Mr. Brown, how are you? And I'm re-engaging that patient in care. That does not take funding. That takes the will. And our EMRs, we're already paying for it. So why not tweak it to suit our needs? So those are some of the little things that I know rural hospitals, it may be difficult to think about, oh, I have to apply for a grant, but those little things can be done.
I just wanted to add to that conversation, Cordella. Thank you for everything. I also just wanted to let folks know that hospitals are often a teaching environment for physicians, and I think that is something we can also leverage. You talked about hospitals being this institution in the community, and I don't want to generalize because hospitals are struggling too, especially in rural communities, but hospitals also have expansive networks where they can recruit providers to come and maybe spend a day at the rural hospital location or another branch of that. And so encouraging hospitals to do that, I think, is something that will help us down the road. And encouraging education. So through grand rounds, through provider education, and just getting to shadow the amazing work that Cordell is doing in the routine screening program sets the groundwork for that work and the sustainability of routine screening to happen. So I think that's just another important.
Thank you so much for mentioning that, because I forgot, rural hospitals can participate in clinical studies. I know there are so many studies out there, but does it reflect the needs of rural communities? We talk about social determinants of health, but what does it look like for people in rural communities? We talk about quality of life issues. Clinical studies can bring forward those voices. If they're done, in hospitals through, we do have an internal medicine program as well at Baptist Hospital. So those issues can be brought forward and can be done with private-public partnerships, because I know all the pharmaceutical companies are interested in learning why patients may not be staying on their medications, and what does it take to get somebody virally suppressed.
Thank you for that. Dina, I want to ask you about technology. We know last year the Biden administration authored a bill to support infrastructure, and particularly around technology in rural areas. How has technology impacted the work of your organization?
I think of technology in two ways. One, the technology that's available to providers and our staff. With, of course, COVID, we had to turn on telehealth. And maybe 2 years before, we had talked about telehealth, and everyone was kind of saying, it's going to take a minute. When COVID came, it took 2 weeks to turn it on and get it going. But also being able to access medical records, other medical information from our hospital partners or other providers. That level of technology has really increased, but it was an investment that we had to make as an organization to put money toward building that infrastructure and being able to tie into the HCCN or clinically integrated networks and really be able to benefit from that technological resource. On the patient end, we thought, man, telehealth is going to be great for our rural patients. They want to come in and they want to see their provider. They want to see. We have a mobile medical clinic, and we take a mobile unit out into the community. We can telehealth for individuals from the mobile unit. They are going to drive to the unit because they want to be face-to-face. It's a very different relational conversation. So it's not just, is there broadband or do they have a signal? Those are definitely key issues. Do they have internet at their home? Where do they have to go to get access to internet? So that's still a challenge, but at the core, and I think everyone would agree, rural patients, they want to have that relationship. We had one provider, and we kept looking at her data, and we're like, oh my God, she's taking so long to see patients in the rural area. Well, that patient would bring in their mom or their brother. Can you look at, and also, or they're coming in with health conditions that have exacerbated to the point where those visits take up way more time than you would expect to see in maybe a more urban setting. So though technology has been a benefit for providers, for organizations to be able to share data in real time and turn on some of these additional access points, part of the conversation is helping our community recognize that there is value in utilizing telehealth. Now, the one thing that's a little different than telehealth is the portal, like our Helo apps and our apps to get our data. That works well. they love it. That is a well used. So we're looking at what are how is it benefiting? Where are we seeing benefit? Where can we maximize? And then where do we need to grow in additional spaces? But across the area, technology has definitely been a benefit. It's just a matter of how do we turn it on and turn it up in some areas.
Thank you for that. Anna Yinsi, thank you. We talked about some of the existential things that rural organizations might face, such as weather. How did your organization work through harsh weather and most recently COVID? How did your organization manage through that in the rural area?
Yeah, so as it was mentioned, a lot of our rural patients do want to see a provider in person, but during that time, I think COVID specifically brought fear to a lot of communities. And so during that time, we were able to utilize telehealth services. We were able to utilize our Can Connect program. And we were really able to try to continue efforts in those ways. Of course, we also would supplement as much testing as possible through the use of home test kits. But our organization actually opened its doors in Arlington, Texas in October of 2020. So that was in the midst of the pandemic. We never, ever shut down, not our prevention, not our testing, not our clinic, because we acknowledged that there was still a need, right? And so with all of the safety precautions that we could possibly take with screenings at the doors, the temperature checks, making sure that our staff and our patients were in PPE necessary, with offering the rapid COVID test, all of those things in combination was how we were able to continue to provide services during that time. I personally remember being in 100-degree weather, full PPE, face mask, your everything. And it was sweaty, but it was worth it because we knew that a lot of other agencies were just not able to keep their doors open during that time. And whether I'm actually native to Arizona, I moved here, so I'm a transplant into the Dallas-Fort Worth area. I never once had to worry about tornadoes. But when that first alarm went off, I had no idea what to do. I am so grateful for our practice administrator. I called her and she said, sit in your closet. So at 9 o'clock in the morning, I took my first meeting in my closet, waited for the sirens to come down, and then, you know, kind of game plan for the rest of the day. But it truly does take our team, myself, my director, our risk management side, to keep an eye on the weather, to keep an eye on kind of those alerts that are coming out and what areas they're expected to impact. And we wait until the last minute to make a call. But ultimately, if it's not going to be safe for our staff to drive out, if it's not going to be safe for community members to be there, then we are going to look at rescheduling. We always want to reschedule, not cancel. But again, keeping safety in mind for everyone in both COVID and weather conditions, it's our number one priority.
And I want to ask that question also to you, Dina. Having a community-based organization, yes, the preparedness can happen, but what does it do to the morale of staff, the morale of community? What does it do to one's well-being that at any given moment where I receive my care or even community can be uprooted?
You know, one of the things, and I completely agree with you, we didn't close during COVID. We had to find a way to stay open and stay available to the community. But Harvey and Imelda, and even the ICE issue, you know, when those things happen, one of the benefits of being in a smaller community is the rallying effect that it has on everyone. Right? We will come together. We will open our facility for disaster-related activities, you know, whether it's having water brought in that you can share with the community, where now it doesn't matter if you're a patient of the health center, you're in the community and you have a particular need. And so that is one of the benefits of being more closely relational in that way. But you know, the struggle is really how do you make that balance happen for your team, right? and for the people that are doing the work. We have at TAN probably 85 to 90% of our staff are women. A good significant portion of that staff are moms and have families. And so having that flexibility and allowing people to live their life, but let's still get the work done, you have no choice because there's not enough of us doing the work to be available. When these guys get called, evenings, we have, of course, non-traditional hours of care. We have the on-call. We have access to the staff. And so trying to make sure that we pour into who's doing the work is extremely critical, but it's also very hard because you want to maybe compensate, right? Financial compensation. You may want to do some of these things, but that also is difficult if you have limited resources. But maintaining that balance for the community when they're in need is critical. And so I'm very grateful that I think we tend to rise to the occasion, especially in those disaster areas, and we're able to partner with our other local government or community organizations to make sure that all of the resources are there at the table. But that balance is definitely a challenge.
Thank you for that. As we continue to look at HIV in rural areas, what recommendations would you provide this body to make your work easier? I won't use the word easy, but what recommendations would you give this body to make your work in rural areas easier? This is a question for everyone.
I would say, I know we talked about funding before, and we're going to keep talking about funding and maybe sound like a broken record here, but I think sometimes our limitations are because of the funding limitations. They don't allow us to utilize funds in different jurisdictions and or areas. And so, of course, again, we get creative on how we're able to provide services in these areas, but it's interesting how something that is awarded to Tarrant County, we know that people commute from Dallas, from Johnson, from all of these surrounding counties for work, play, etc. Yet we are not able to provide services in those areas because of just what a paper says. So really pushing to be able to have the flexibility there, I think, is important.
So thank you for sharing that, and I think that is definitely something that's important. When I came in as the prevention director at DSHS, that was one of the things that we changed in our RFPs, was because we recognize that the impact of organizations can have not only in their local community but also statewide. We have several examples of organizations that have done that successfully to provide, because telehealth, for example, doesn't have boundaries or borders. I mean, yes, in terms of state law, but yes, to be able to have the options to do that, to have the flexibility in funding. I think another recommendation that I would add is there are, to my knowledge, there are no interventions or specific prevention strategies that were developed or intended for rural communities, rural communities, people who inject drugs, non-white MSM populations in rural communities. And so I think that is something that we also looked at changing. So rather than only stick with the evidence-based interventions, the EBIs, or the interventions that were designed in urban areas that then were either adapted or modified to another population, it's hard to really look at that and understand, is that really something that you can generalize to any setting? So we wanted to open that up and have communities identify what their own needs were, and to lead with their own interventions and options, and to be innovative and to give them that flexibility to do that. So I think that is something we also need to look at.
One of the things that I think would help rural communities in understanding the logistics of how difficult it is for people to get to care is, in that same RFP, providing the opportunity to fund spaces like Unite Us, which is a platform that connects clinical and social work. It's HIPAA and FERPA secure, and I do not work for Unite Us, but it is a useful tool that I can send a referral from the Ryan White facility to the housing authority to get somebody into that housing program without having my patient leave my office, try to find a bus, take off from work to get to the other side of the county for housing. And then a lot of times, even with referrals, we don't know if the patient made that connection until they're back in the ER 3 months later, telling us they couldn't go because the supervisor threatened to fire them if they took another day off from work. But this is a useful tool that allows the person who you refer the patient to tell you if that patient made the appointment, what the steps were, and what the outcome is. But that allows, instead of saying, oh, funding, put it in the RFP and allow us all to be able to talk to each other in how we're linking patients to care and making sure patients don't have to figure out how to take off. It's an entire day from work for somebody who's not salaried. It's an entire day from work for somebody who gets paid daily. And those are the issues that our people in the rural communities face.
I think for me, the definition of what is rural is important. We have a brick and mortar site in Beaumont, and we have a brick and mortar site in Orange. And of course, we have the mobile clinic that travels the full 6 counties. But from our brick and mortar in Beaumont to our furthest location is 2 hours that we have to drive to get there and get back. I can't apply for any rural state funding at all because I don't have a brick and mortar in what the state considers a rural area, right? And so I have to look for other sources to continue to provide the range of services that are actually needed in some of these spaces. And so I think looking at what does that look like, and anyone who has space to have that conversation, what does rural really look like? Jefferson County, Orange County, and Hardin County, which are southeast and all the way going to the Louisiana border, they're not considered rural. I don't know how that's possible. That's not a rural area, and so the resources that are available to where the hub of people exist aren't there, but then we can't have EHE either. So how do we make any of these things happen if we're not fitting in any of the defined definitions? So that's definitely one space. And of course, I go back to infrastructure. And if we need to, we are happy to invite everyone down to Southeast Texas to really take a look at how should our infrastructure be formatted? How should we look at and who are the partners that we want to include and incorporate? We're starting now from a cluster detection we had earlier last year. We're starting to look at engaging with private providers who actually offer testing. And we looked at the list and went, they offer testing. And so we need to continue to make these relationships. But when you had asked the question, how does Cordella work with, or hospitals work with the CBOs, there's 3 of us. So that's 4 people. We have lunch, right? There's not enough of us doing the work or engaging. And so I think being able to make the resources more available and establishing more collaborations in that public-private space is another way that we can really maximize the resources that we currently have.
I want to ask one more question before I open it up to my colleagues to ask our panelists questions. You mentioned EHE. What should PACHA understand in regard to advancing EHE work in rural contexts?
Well, EHE is not visible in rural communities. So there needs to be visibility. As Dina just said, we're not EHE and we're not rural. We're there, we're just there. But my question then is, where do we go from here? We're halfway through EHE. Is there then the opportunity to extend EHE to rural communities, having those who are already funded say, okay, now you have a template, get a rural partner. In this age of technology, we can share our data. In this age of technology, we can share our skill set. So is that an opportunity? Then okay, we won't be funded, but should those who've already been working for 5 years have something ready to be replicated, and then they can build other communities from what they've done over the last 5 years?
I would add to that. I think laying the groundwork and getting ready now to extend the EHE initiatives into rural areas. I know there are some states that are funded statewide EHE activities because the predominant, or the states like South Carolina, where the majority of HIV prevalence is in rural communities in that state, and so learning lessons from those states and that have significant HIV prevalence in rural areas, and translating those innovative interventions into other rural communities. That is work that we can start doing now. We don't, again, the capacity building, the support, those are things that can help rural communities more. Yes, with funding, but I think that support, the peer-to-peer networks, and workforce development are all things we can start to do now.
I think the innovation is another area. Being so close to Houston and being from Houston, having access to resources like, the health department or other CBOs, we work together because we recognize that the I-10 corridor, it's 90 minutes to get from one end to the other. And so we want to make sure that we have the same resources so that individuals don't, particularly those who still struggle with the stigma around a new diagnosis, don't feel like they have to go all the way to Houston for care. We want to be able to have all of the resources available in our own community to be able to support them long term. So I would add, that particular piece to that conversation.
Thank you. I would now like to open up the floor to my colleagues who have questions. If you could raise your tents, if there are any. I will start to my right, Marlene.
I just want to thank you, Marvell, for facilitating and really guiding us through this conversation this morning. And thanks to all of the panelists. Really appreciate your important insights about what we should be considering about how to better support the work that is underway in rural communities. I have a specific question around healthcare access and some of the strategies you may have taken. And in context, I was thinking about a report that came out a couple of years ago where it described the proliferation, if you will, of community health clinics over the past 10 years in Texas, and they did some analysis county by county. But one of the things that was illuminating to me from that report is, despite this growing proliferation of community-based health clinics, FQHCs, et cetera, there was a reduction in the number of patients who actually were able to access those services in the same time frame. And so I'm curious as to some of your, and you talked about some of the reasons why, transportation, obviously, hours of access, et cetera, but can you share some successes that you've had in ensuring that you maintain the level of access that's appropriate, that makes sense for the kinds of needs that you see in your communities?
And again, we're a 8-year-old FQHC, so we're still in baby steps. We're still working through. But because we were an AIDS service organization, we were able to maintain some of the processes that were already in place that we were successfully doing. We, in addition to having rapid HIV screening available for HIV, HCV, and syphilis, there's a rapid avenue. We also do routine screening in our visits, same as Cordella and Baptist. And so we want to make sure we have dual routes of access for individuals depending what they're coming into the health center for. In our rapid screening situation, if a person has a initial positive reaction, then that individual is immediately placed on the provider schedule. There is no wait. There is no who's next. They immediately go right across the walkway and they're placed on her schedule. Staff are fully educated from front desk all the way through to care management and how to navigate, how to access medication assistance, insurance. And so that routine and that rhythm, because we've done it for so long, it's supernatural to how we move. And I think it's one of the reasons why, again, you may struggle with coming to TAN because you don't know that we do a lot of other things. But when it comes to an HIV or an STI diagnosis, you know exactly where to go for that support. And so that's one of the real benefits. And it's a trust building relationship as well. Because when you're in the situation and, you know, the stigma, the disclosure, the confidentiality, it is exacerbated in rural communities. It is huge. I mean, and I have to give super love to DeAndre because he came in and single-handedly popped the bubble with his amazing campaign. And we love and appreciate you for everything that you did to really normalize living with HIV in the community, but having to navigate that space, being a part of a team that knows exactly how to move a person gracefully, because it's that first and initial relationship that you have that's going to testify to the rest of how you navigate your own care. And so that's definitely one of the things I am super proud of this team, because when that hits, when we have a new diagnosis, and they come in, they're constantly coming in. The response and that navigation is simply phenomenal. It really is.
Thank you. Alicia?
Thank you all for sharing as you have about the rural areas. This question is for Cordella. You mentioned that the rural hospitals can participate in clinical studies, and understanding the historical trauma that has impacted Black and brown bodies over the centuries, contributing to mistrust in the medical system. How do you all connect patients with clinical studies so that they know they're available? And are there advertisements in the clinics, social workers or research assistants available to speak with patients to tell them about these available studies? And if so, are there pushback from the patients?
Thank you. Yes, we do have a research team that is diverse. Our care team is culturally diverse as well. And Yuri, our patient navigator who's listening online, she is a member of the Hispanic community and, represents what Beaumont looks like. We provide the information and we follow the guidelines of the study in how patients are brought into the clinical study. One study we currently have is for patients who are newly diagnosed with HIV. So it starts there. There is no promotion going on in the clinic. This is something that's pretty much done as one-on-one as we meet patients who meet the criteria for the studies. And we give them the objective information and we stay available and accessible to answer questions. And they know that this is it's a volunteer, they're not mandated to do it. It's all about having the frank discussions. As I said, again, with hospitals, it's building trust, and people first start trusting who they can relate to until we prove otherwise. And that's where our team comes in making sure, have you ever had the opportunity where you try to When you know it's a scam, when they tell you you have to sign up today. Well, so that's not how it is with us. It is the information in a language they understand, being available and accessible to answer questions, having them know this is voluntary, and everything else along the way. Now, it's not a clinical trial. These medications have already been approved by FDA. It is a clinical study. We may be looking at the more social impact of it, which is an easier promotion, if you will, because then they know it's already FDA approved. They would have gotten it anyways, but you're in the study to see how, things are based on race or, gender or something like that. So, we begin with trust and having patients understand they are in charge. Right.
Thank you. I have a queue. Arnia, Carol, Duvia, and Guillermo, and DeAndre. After that, we will need to move forward.
Thank you so much, Marvella. You've asked the best questions. I barely have a question to ask. And thank you to the panel for personalizing what it means to be in service to rural communities. It really helps us get smart in the most intentional way. My question is for Dina. I'm claiming Dina. We're two Hugheses in the house. I don't know that she claims me, but I am claiming you. So as a FQHC, you've been on a journey with the Bureau of Primary Health Care with the federal government to submit patient-level data. And so I wonder if you can share with me what you want us to be most mindful of as we enter into that process. I mean, that is a very specific road to travel that needs to be done with great care and attention. And so you certainly have my attention. And so what do you want me to think about most as you think about the process of submitting patient-level data to us?
Absolutely. I think for us, it's being able to give a comprehensive and full picture of our patient population. Though we have a diagnostic avenue, we also have a lived experience avenue in terms of where are our patients now. We were talking yesterday about how many of us are growing, we're getting older, and we're looking at HIV and aging, but we're also looking at diabetes, we're looking at hypertension, we're looking at this larger story that we have to tell about the needs and the care of our patients, and then the ultimate cost of our patients. So being able to, we're learning how to use the data better as well. In talking about technology, we're now implementing Azara Health, where we can get more real-time data, we can get more real-time access to what's going on with our patients. We're focusing more on value-based care and taking that approach to making sure that we're incorporating prevention and we're incorporating screenings at particular levels for people to really be knowledgeable so that we can prevent or at least get a heads up on critical issues that an individual may be living with. So for us, we're trying to learn more. We're trying to learn more how to tell the right story, because oftentimes sitting in a rural seat, I can't say I serve thousands. I don't. But what I have, it's often deeper, and the issues are more substantive in terms of SDOH and other concerns. It's a thicker, denser situation that we often find ourselves in, because we are dealing with the stigma. I was asked the question the other day, can we find some people who would be willing, HIV positive people, who would be willing to talk about HIV and aging on camera? I called in my care manager. I said, hey, listen, I need to get about 5 or 6 people. And she just looked at me like, girl, you're not about to get that. So we ended up engaging in a conversation around, well, is it stigma? What does it really mean? And it's not stigma as in I'm ashamed, I'm embarrassed, I don't want anyone to know, but the normal life that people are living, taking their meds, compliant, having a great life, there's no reason to upset that by being vocal. They're not against being vocal. They'll support you, but the normal. And so how do we really talk even about stigma? Because they're not stigmatized. They're perfectly fine, but they're not interested in having everyone look at them at Antioch Baptist Church on Sunday. That's not what they want to do. And so for us, I think we're learning, honestly, how to communicate this information better to you. So I'll share that. I want you to know this. I'm still learning how to tell the rural story better. What is the data that really says to you, oh my goodness, HCV is huge. So when we test for HIV, we also do HCV screening as well. And we had a partnership a few years ago with a pharmaceutical company. And when he looked at our data, he went, oh my God, did you know? No, is it bad? And so we're starting to, that's why I think we need more help with how do we interpret and communicate what's going on in our space? How does it compare? Maybe not in actual number, but in application in a particular area that's not an urban setting. So we're claimed, and I hope we can continue to have that conversation, and with the data that we're able to generate in a much more robust fashion, be able to tell a better story of our need, and of course, but then also what we're doing really well that can be scaled up other places.
Thank you. For the purpose of time, we're going to double up on the questions. So we have Carol and Devia. Am I pronouncing it correct? Okay. If you all can go together, ask your questions, and then we'll get the panelists.
Mine is just a quick comment. First of all, thank you for putting together such a smart and insightful panel. This has really been remarkable. There are two things that were highlighted in this that I don't hear enough around these tables, and that is the impact of climate change, and in particular on housing. And what that means then downstream. And then the other thing that I don't often hear, and I'm really grateful to hear, is about the role of hospitals and hospital-based care, because that is the reality in many places, and including rural settings. And so those partnerships that include hospitals, we don't hear enough about. So thank you for that.
Thank you so much.
Thank you to our panel of experts. My question was surrounding the Latinx community and the immigration trend. Are you seeing a higher demand as we see that immigration is increasing in the state of Texas? Are we seeing Latinx and other immigrants placing a higher demand on the need for care for HIV services? What are some of those barriers that you're seeing with uninsured, underinsured, and undocumented individuals? And what are some of the recommendations that PACHA can take back and elevate to our Secretary of Health and Human Services to assist you in eliminating these barriers to care?
Thank you. Yesterday, I talk about private-public partnerships that hospitals can engage in. And one of our biggest partners, Gilead Sciences, allowed us to overlay HCV testing on our already existing HIV platform. And we're grateful for that, because then we extended that partnership into prevention, where we're now identifying people who have a reactive STI and interacting with them to get them into prevention, whatever it looks like, be it PrEP or something else. And through these modalities, we are finding ways to engage with the community at the level where they understand HIV and prevention. We're also finding out what is a priority to them. It's a priority to me to link somebody to care or to do testing. Maybe somebody's priority is getting food that day. Through our partnerships also, yesterday, one of our reps met with a group of Hispanic ladies at a Catholic church and talked about sex and STIs. And so Mr. Daniel Ramos, I don't know if he's in the room. There he is. Thank you, Daniel. He went down to South County and he interacted. We take the message to the people. That's it. We're not expecting people to find us. We do know there's an increase in the number of immigrants who are in our community. Now, everybody does not speak Spanish. We do understand that as well. So there is this, there could be language barriers for those who speak a different language as their native language. And as we go out and we find these groups on Facebook and wherever they meet, some of them, they do meet in a setting where they're doing ESL, We understand that those are the advocates for the community, and they're the ones who we want to speak with first. I say this all the time, building trust, is that we go in, we let them tell us what they need from us. We share the resources that we have. It's not all about HIV. It's about, let us get to the common ground, then we can start having other discussions. And so we'll be meeting with the Facebook group that are doing ESL. And that's another one of the issues that we can address with people who do not speak English as a first language, is crafting grants so that those who receive that funding can have space to help people learn English. Just be confident in English as a primary language, because as an immigrant, I can tell you, we're not confident when we first get here because we say things differently and we sound funny. But we do want to advocate for ourselves. And if we have those spaces where we can learn to be confident in speaking English, then we become the advocates, not just for healthcare. We will speak to our landlord. We will speak to our school principals. We will seek a job that does not require English, Spanish as a language, because yes, it's nice to have a Spanish provider, but how many Spanish providers are we going to get? So why don't we teach people to be confident? These are very smart people. They're just not confident in speaking English. So creating that space could also help. And that is why we're going to the ESL spaces, because maybe we too will learn their language and then be better able at connecting and communicating. So that's one of the things that we're doing as a hospital, because we're neutral.
Thank you. DeAndre and Guillermo, no question. DeAndre.
I have a comment. Is it okay? I'll try to be brief as I can. I just want to say thank you to these ladies, to all of the entire panel. Samuel, Ms. Amarez, thank you all so much for being here. I want people to realize that Beaumont is actually a rural area. No matter how the state tries to define it, it takes me an hour to get here. Most people it's an hour and 30 minutes, but I have sport mode on my car. And in Texas, we do believe in 75 and 85 mile per hour freeways. So and you will get pulled over for not going fast enough here. But I say that to say it because being home in Beaumont, when I left Beaumont at 18 years old to go off to college, I swore I was never going back. It was too slow. There's nothing there for me. When I got a positive diagnosis, I knew that I couldn't go back because I didn't think that the healthcare was going to be sufficient enough for what I needed as a young Black queer man in the South. But for some reason, I can remember this lady right here from Baptist Hospital, Ms. Cordelia Lyon, calling me one day. It was coming up on World AIDS Day 2015-ish, and I just launched this campaign. And she said, I want you to come back to Beaumont from school, drive 3 hours down, and come give a speech for World AIDS Day. I said, oh, okay, cool. I'm in college. You know, what are you paying? What's it going to look like? She said, oh, we don't have funding, she said, but what I can do is I can take you to Carrabba's for lunch. And that's exactly what we did. And I came down and we did that. But what was so innovative and interesting around this time was that this lady had people on stage talking about PrEP in Beaumont when people didn't even really know what HIV was. And she took the resources that she had out of her own money and stuff to make sure that she was able to make that impact, and to watch it grow over time and be so innovative. It's just remarkable. And then to Ms. Dina, as someone who's lived all over the country, like I said, I was never supposed to go back to Beaumont. Lived in Houston, lived in Dallas, lived in Atlanta. But something about Atlanta, baby, I was having too much fun. I had to get back home. And so I did come back home. But full transparent moment, last year around this time, I resigned from my full-time job as a full-time employee with full benefits and everything. And so for the first time in my life, what that meant for me was that I was no longer going to have access to insurance. And I was nervous about what that meant. And so before I left Atlanta, I remember going to my doctor, which was a Black queer man in Atlanta, never saw anything like it before. I requested to see if they would provide me with at least 3 months of medications, because I knew what was about to happen. I wouldn't have insurance, I wouldn't have access, and so on and so forth. So they did it. And I can remember one day at my restaurant, Ms. Dina comes in and she's there. She starts talking to me about my healthcare and like, hey, you know, where are you going? I know you're here. And I actually lied. I said, well, I go to Atlanta when I can. And she looked at me and she said, and excuse my language, the fuck are you doing way to Atlanta? She said, do you not know what we have right here in Beaumont? And I said, I mean, I know that there's clinics and stuff. I said, but I'm just afraid of going somewhere where I won't find anybody who looks like me and who will understand me. And she says, somebody's going to call you tomorrow. You better answer that phone. And something about a Black woman that's not your mama telling you what you're going to do in the South is just, you just do it. That's just exactly what happens. I've had the same thing with Marlene calling me before. I used to make these posts on Facebook. She called me one day. She said, I need you to come to my office. I don't even work for you, lady, but I'm on my way. I'm coming. I guess I got to go. And we had a come to Jesus moment, and that's just what it is. But she did that, and I got the call from TAN, and I'm like, okay, they're making me an appointment. How am I going to tell them that I don't have insurance? What will this mean for me? Go in, the first person at the front desk, a Black woman. Okay, this is different. Cool. She knows everything that she's talking about. She makes me feel welcome. Go into the doctor's office. Nurse that comes in, Latina woman, makes me feel welcome. I feel so, inspired. I'm just thankful to be here in this moment. I'm like, okay, let's see who this doctor is, who it's going to be. And then comes another lady, a Black lady comes in. I was like, damn, they got two nurses. She says, hi, I'm your doctor. My name is Dr. Maisha. She's sitting right back there. She said, I'm your doctor. And this lady sits down. Usually doctors don't have enough time to sit down, but she took the moment to sit down and go over with me where I was, how I was doing, asked about my mental health and so on and so forth. And they got me access to care. And so for the first time in my life, again, I felt so welcome, and I was able to get access to care in a place that I thought was not sufficient enough to take care of me, which is my rural hometown, Beaumont, Texas. And so to you, Ms. Dina and Ms. Cordelia, I want to say thank you for that. And I also want to notate that Ms. Dina Hughes and Ms. Gloria right here both came to my restaurant again, and they said, we want to come here and we want to talk about HIV in this establishment. We want to come to your restaurant. We want to bring together a group of women, and we want to launch the Texas Black Women's Healthcare Initiative right here in this restaurant. Is that okay? And I look around and say, hell yeah, that's okay. We should absolutely do that. And so congratulations to you ladies for doing that, because last month they were able to bring together about 20, 25 plus women into my restaurant where they had displays and they were actively talking about HIV in a restaurant surrounded by other people. And that was really life-changing. And I just want to, again, but even without the resources, these ladies and these rural areas are still making a difference and an impact on so many people's lives. So thank you so much.
Awesome, awesome. Can you help me celebrate this esteemed panel that we've had today? Yes. I will now turn it back over to Madam Chair.
Thank you, Marvell. You know, when you do an outstanding job leading something, it turns into a full-time gig. So we will call you again to facilitate important PACHA conversations. I appreciate you. I just wanted to take a moment before we go into our break to recognize an individual here in the Houston area. I started the day yesterday with describing some of the artwork that you see around the room and in the hall. It's all part of an 8-year-long effort initiated by Mr. Corey Garrett. Art on the Streets World AIDS Day Project is a collaboration between a school district, the health department, community organizations. All the artwork is created by local students. I've had folks ask me since yesterday, is the art for sale? Want to learn more about the project. And as you know, extremely successful project, over 5 million impressions generated since its inception. And it's been presented at most major conferences, NACHO, APHA, NCSD. Corey, please stand up. Let the people recognize you. For those who are interested in the artwork, talk to Corey. He's right there. And we will take a break. We will come back right at 10:50, and we will continue this amazing conversation shifting into urban perspectives. Thank you. 10:50.
Produced by the U.S. Department of Health and Human Services.